Okay. Well, good morning again, everybody. It's a pleasure to be able to co-chair this hearing this morning. This is a joint hearing of the Communications and Technology Committee and the Health Committee. We are joined by my co-chair, Representative Kathy Rapp of the Health Committee, and Representative Cerisi, who is the majority chair of the Communications and Technology Committee, and Representative Ortite, who is the Republican minority chair. And I will give them an opportunity to make some opening remarks after I finish mine and have members who are with us today introduce themselves. So let me just start by thanking all of you for your attendance and for your patience with the many challenges of bringing these committees together to learn more about artificial intelligence and its use in health settings. It has been a chore trying to get this together given the challenges of the weather. Yeah, originally, we'd planned to have this meeting alongside the budget hearings, which were canceled for the beginning of this week. Due to the uncertainty of the snow and because we wanted to make sure legislators would be present to hear these materials, we will be holding the meeting virtually and hearing from the first panel of speakers who would all have been virtual regardless. We will reschedule the second panel for a later date. I'm very excited to begin this conversation about artificial intelligence in healthcare. We hear a lot about AI in the news, and sometimes the narrative seems like a 1950s horror movie. The robots are coming, an epic battle between humans and robots that could become smarter than us and take over. Those existential questions are fascinating, and I'd love to talk about it offline, but that's not what this meeting is about. The experts testifying before us today are going to help us dive deeper into how AI is going to impact our healthcare, the quality of care provided, the value that we're paying for it, and the impact on our healthcare workforce. They will hopefully help us to think deeply about the issues we as legislators need to consider as we discuss the guardrails for the new technology. How do we make sure that these tools work for us as patients, as caregivers, and as payers as well? Before I turn to my chairs, I would ask our members to try and do this as organized as possible to introduce themselves. And I see Representative Venkat, if you can start us off.
Here, I'm sorry, Chair Frankel, I'm out of town, but I'm listening in.
All right. Introduce yourself and your district.
Oh, sorry. State Representative Arvind Venkat. I'm in the 30th Legislative District in the North Hills suburbs of Allegheny County.
See Marla.
Good morning, Chair. This is Marla Brown. I represent District 9, which is Lawrence County.
Representative Twerzik.
Morning, Chairman. It's great to join everybody here. I represent the 123rd District in beautiful Schuylkill County.
Representative Krupa.
Charity Krupa, I represent the 51st District, and I'm happy to listen in. Thank you.
State Representative Valerie Gatos. I represent the 44th District of Allegheny County, and I'm also interested in listening in, so thank you for putting this on.
Right. Representative Rusnak.
Good morning, Representative Rusnak here from the 126th District, which is Berks County.
Representative Schusterman.
Representative Schusterman from Chester County.
Representative Zimmerman.
Yes, Representative Zimmerman, Northeast Lancaster County, Southern Berks, and appreciate you putting on a timely issue, so thank you.
Representative Doherty.
Hi, Chairman. Thank you so much for hosting this. Sean Doherty, represent the 172nd District, Philadelphia County. Thank you so much.
Representative Stair.
Good morning. Thank you, Chairman, for putting this on. Representative Joanne Stair from the 107th, covering parts of Northumberland and Schuylkill counties.
Representative Borowski.
Good morning, Chair Frankel and Chairs. Thank you for hosting this. Lisa Borowski, 168th from Snowy, Delaware County.
Representative Prokopiak.
Morning. Thank you, Chair. Jim Prokopiak, 140th District, Lower Bucks County.
And Representative Takak. I'll turn it over to Representative Sanchez.
My apologies, Chair. Paul Takak, representing the 82nd District in Center County. Thank you.
And good morning, everybody. Ben Sanchez from Montgomery County.
All right. I think I have everybody I've seen. If I've missed somebody, please speak up.
Chairman Frankel, this is Chairman Rapp from the 65th District, Warren, Forest, and parts of Crawford. So thank you, Mr. Chairman, for chairing today, and I'll be listening in to the information provided. Thank you, sir.
I was going to turn to you for any opening comments, Chair Rapp, if you are interested in doing that.
Well, I just want to welcome the testifiers. I think this is an important subject, combining, artificial intelligence and the healthcare system. I'm looking forward to hearing whether or not this will be saving money for consumers in healthcare, and also how technology is, and we're already seeing technology obviously within our healthcare system, but how that will be developing even more, hopefully to alleviate some of the issues that we have with staff or just issues in general regarding healthcare in the state of Pennsylvania. So thank you, Mr. Chairman, for inviting the testifiers, and I'm looking forward to the information.
I see Representative Pauline Nelson has joined us as well. Representative Cerisi, Chair Cerisi, do you have some opening remarks?
Yes, thank you, Chairman Frankel, Chairman Rabb, Chairman Otitai. This is a great subject for us to be able to speak with. As we know, Representative Venkat has a bill that speaks about AI in medicine, and we had a 3-hour hearing a few months ago, seems like forever ago, in Harrisburg, and heard from so many different organizations. But we need to be cognitive of where we go with AI. And the best thing, of course, is the savings of money and being able to diagnose different diseases quicker. The worst thing is allowing a computer to be able to do this without human interaction. And there's a balancing act that goes on here. I look forward to today's testimony, and thank you for the hearing.
Okay. And we also have Chair Otitai. I don't think he had planned to make any opening remarks. So I'm going to turn this over to our panel. And what I think we'll do is have all three presentations and then turn it over to members for your questions and comments. And I'm going to ask those who are presenting at this hearing this morning if they could give us a brief introduction of their backgrounds. And we're going to start. We have three testifiers here. We're starting with Dr. Hannah Neprash, who's, I guess, speaking on artificial intelligence in healthcare spending. So let me turn it over to Dr. Neprash.
Thank you, Chair Frankel. I am thrilled to be here. I'm joining you from Minnesota. I'm so sorry that we shared our snowy weather with you in the past week or so. I am a healthcare economist by training, so I, like you, am fascinated with some of the questions around how artificial intelligence will change the way we spend money on healthcare and hopefully improve the value of our healthcare spending. Next slide, please. So I want to start with a quick terminology refresher to make sure I don't go too far into the jargon. I suspect a lot of people have heard the distinction between predictive AI and generative AI. I think of predictive AI as a tool where you that analyzes data and gives you a prediction about whether a condition is present or maybe whether somebody is likely to be readmitted to the hospital. Those are two very common applications of predictive AI in healthcare. In contrast, generative AI is probably more in the news right now. Any chatbot or large language model is going to be an example of generative AI, which broadly speaking produces new content. Next, please. Healthcare spending needs no definition, but I do want to point out that you can think about healthcare spending from different perspectives. Some of those being the perspective of patients, consumers, insurers, and of course, taxpayers. Also, high value care, I will talk about that here. Broadly defined as maximizing the health benefit for patients relative to the cost. So our goal might not be to reduce spending, but to improve value. Next slide, please. So I want to start with the glass half full side of things, which is to give you a couple of ways in which artificial intelligence might decrease our healthcare spending. The first example is AI has the potential to simplify administrative tasks in healthcare, of which there are many. But two examples come to mind that are currently being used widely. The first is AI-enabled call center automation, and the second is AI-enabled tools that submit and deal with returning responses for prior authorization requests. Next, please. AI also stands to potentially reduce healthcare spending by reducing burnout-driven clinician turnover. I highlight this because one of the most expensive things for healthcare delivery organizations is replacing clinical staff when they leave, and burnout is a key driver of workforce turnover. There's a lot of enthusiasm and tremendous adoption of AI-enabled documentation tools, also known as ambient scribes, which use transcription technology and then AI algorithms to draft clinical notes for clinicians and reduce that documentation burden so that clinicians can spend more face-to-face time with their patients, potentially allowing them to stay in the workforce and stay at their current jobs longer by reducing burnout. Next, please. And of course, I should say that AI has the potential to decrease spending by accelerating diagnosis and preventing the progression of disease. So here the example I give you is a widely used coronary artery disease algorithm that applies artificial intelligence to analyze CT scans of the heart and predict the presence of coronary artery disease before it gets to the severity of causing a heart attack or another cardiac adverse event. Next slide, please. All right, so on the flip side, AI has the potential certainly to increase spending. I have four ways I wanna walk you through. First is simply by expanding the treated population. So here a good example would be AI-enabled diabetic retinopathy screening. These are some of the only autonomous AI tools that are currently approved by the FDA, and they hold tremendous potential to expand access to recommended diabetic retinopathy screening, which should be happening every year for patients with diabetes, but it's not. If this does expand access, it of course is also going to expand the population of people diagnosed with diabetic retinopathy who require further treatment. So that is how it might increase spending. Next, please. AI, unfortunately, also has the potential to identify what experts refer to as clinically insignificant findings. AI is very good at pattern matching. That is essentially what predictive AI can do. And there are many applications that reanalyze old images for conditions beyond what the initial scan was meant to detect. This may turn up incredibly meaningful findings. It can also turn up clinically insignificant findings. Either way, when there are new findings discovered, there needs to be follow-up care, and that is additional spending. Next, please. Of course, when we pay for AI by adding more billable codes, that is an invitation for clinicians to request reimbursement when they use AI. This is not necessarily a bad thing, but it is something that tends to increase our spending on artificial intelligence. If you think about what Medicare is currently reimbursing for, there are about 1,500 FDA-approved AI-enabled medical devices currently on the market. Medicare reimburses for less than 5% of that 1,500 number. So this is still in its infancy. Next, please. This is one that a lot of people are talking about right now. AI has the potential to increase healthcare spending by simply facilitating higher intensity billing and coding. Here, I return to the example of ambient scribes, a lot of which have billing and documentation functions built in, and part of the way they market themselves to healthcare delivery organizations is as a tool to maximize reimbursements and maximize diagnostic coding. That is fantastic for healthcare delivery organizations and problematic for broader healthcare spending trends. Next slide, please. All right, so as a health economist, I'm always looking at the evidence to try to answer big questions like how AI will affect healthcare spending. Historically, it's worth pointing out that in healthcare, new technology tends to increase rather than decrease spending. That is one of the many things that makes healthcare special, right? Compare this to, say, television technology. TVs are better and cheaper today than they have ever been. But in healthcare, new technology tends to increase spending. Next, please. We don't have very much high quality evidence right now about what AI-enabled technology specifically will do to spending. I point out, I italicize high quality because there is a lot of vendor provided evidence, but I think we should all take that with as many grains of salt as possible. However, there is some high quality, early evidence points to a bit of a mixed picture. On one hand, there's evidence that spending increases when clinicians adopt AI-enabled coronary artery disease algorithms, but you also see a decrease in cardiac adverse events, which suggests that this may be high-value spending and there may be savings down the line. We also see that when clinicians adopt ambient scribes, there's a small reduction in documentation burden, but there's also an increase in billing intensity that translates into higher spending. Next slide, please. And this is my absolute last slide. These are questions that I ask myself when I want to assess the value of AI. There are four questions. The first is, who bears the cost of the AI tool? Is it patients? Is it healthcare providers themselves? Is it payers of healthcare, either employers or public insurance programs? This can be a good indication of how the revenue is flowing and who thinks the tool is valuable. Second, who is setting the price for an AI-enabled service, and what is that price based on? If developers are setting the price, it's not necessarily true that the price will be close to the marginal cost of providing a service. There may be a markup, and that is something that, of course, public insurance programs aren't enthusiastic about paying monopoly rents to developers. Relatedly, are there multiple developers providing similar tools? Of course, I'm an economist. I would ask this, but this is basically asking, is there competition in the market for a particular AI tool? If there is, that's fantastic. That suggests that we're getting high value there. And finally, most importantly, I think, how does the tool perform in the real world? That is distinguished from how does it perform in a clinical trial? Because of course, all of these phenomenal technology advances that apply AI to healthcare run into the fact that we already have a complicated healthcare system, and it's important to know how something performs in the wild. I will stop there. Thank you very much for the opportunity to share my thoughts, and I'm happy to answer questions after.
Thank you, Dr. Nepresh. Are you able to hang in there with us through the other two presentations, and then we'll open it up for questions?
I am. I will stick around.
Great, thank you so much. Our second presenter is Paige Nong. And Paige, if you would introduce yourself, Dr. Paige Nong, excuse me, if you would introduce yourself and proceed. Thank you.
Certainly. Good morning. Thank you to the chairs for having me this morning. I'm excited to talk with you about AI implementation in healthcare and considerations for quality. My name is Paige Nong. I'm an assistant professor in the Division of Health Policy and Management at the University of Minnesota. We can go to the next slide, please. The timing of this conversation is wonderful because we are in a kind of complicated liminal space between widespread availability of AI tools in healthcare and increasing implementation, and the kind of robust empirical evidence that we need and want to make good decisions about implementation in healthcare. There are complicated and important questions to ask here. And so what I'm going to do with the remainder of my time is to give you a quick snapshot of what AI use actually looks like across the US healthcare system today. There's lots of hype and lots of excitement, but we'll get a sense of what it actually looks like in the healthcare system. And then we will talk a little bit about some of the hopes and risks when we're thinking about quality of healthcare and why quality presents such a challenge across lots of different types of healthcare delivery organizations. We can go to the next slide, please. Dr. Nepresh did a wonderful job of explaining this distinction between predictive and generative AI, and so we won't dive too deeply into it, but one additional piece that I'll add is a really important consideration that complicates our efforts to identify quality of AI tools. For predictive tools that are kind of consistently identifying patterns in historical data, and then we apply those to patients today, those tools tend to be deterministic, which means if I put in the same numbers today and tomorrow, I will get the same answer both times. With generative AI,
Dr. Nong, I think we lost you there.
and so for the healthcare delivery organizations that are trying to, design governance strategies and think about how they're going to use these tools, that aspect of generative AI makes it really tricky. It is hard to evaluate something when with the same input at different times, you get different output. So we kind of have good best practices for evaluating predictive AI. It's been around for quite some time, but generative AI presents this real challenge for quality, but it really does present a little bit of a methodological puzzle for them. Next slide, please. So in terms of what AI use actually looks like in the healthcare system today, using data from 2024, we identified
we're having some technical issues coming in and out, Dr. Nong. I'm not sure where that's coming from, but.
Oh, maybe my connection is bad. Can you hear me now?
Yes. Let's see how it goes. Okay, thanks. We've kind of lost you there. I don't know if it's on our end, Patrick.
No, it's not on our end.
Can you hear me now?
Yeah, we just could hear you, yes. It seems like you come in for a while and then it you know, you-
Not stream images or not just do her voice.
what's Erica? What did you?
Just think maybe she could not try to stream the visual and just do the audio, so that there's better connection issues to reduce connection problems. There we go. Yeah.
Okay. All right. Let's see how it goes. All right. Dr. Noam, maybe you can proceed. Let's see how it goes.
Okay, can you hear me okay now?
Yes. No, we're not getting you. We are not hearing you.
Can you hear me okay now?
Right now, yes.
Okay, let's try that. I switched networks, so we'll see if this works better. Maybe we should go back one slide. No, I think it's fine to stay here. In terms of what AI use looks like in the healthcare system today, we know that in 2024, about 71% of hospitals were using predictive AI. That technology has been around for quite some time, and we see relatively widespread use. But really interestingly, we saw that almost a third of hospitals had already deployed some type of generative AI in 2024. As far as technology implementation in the healthcare system goes, that's really quick. The healthcare system is not known for its rapid technological transformation, but in 2024, almost a third of hospitals were already using generative AI. Next, please. We do importantly see a digital divide here across different types of hospitals. So hospitals that are part of a larger system and those that have higher operating margins are much more likely than their counterparts to be implementing these kinds of tools. Rural hospitals and critical access hospitals are less likely to both use and, importantly, evaluate AI tools. Evaluation is critically important to make sure that a tool is working properly for a patient population. And so we see a digital divide not only in the ability to implement tools, but also to evaluate them and make sure that they're operating well in practice. Next slide, please. AI is a very broad umbrella term, and we talked about the distinction between predictive and generative tools, but there are also fundamental differences in how we apply those tools across the care continuum. So a patient's care from scheduling through diagnosis and treatment, through follow-up, and even through billing can all be shaped by AI tools of various types. So we wanted to understand which kinds of tools are hospitals using most often. Next slide, please. The most common applications are actually for scheduling, for predicting adverse events like sepsis, and doing follow-up and monitoring. So that would include a tool like predicting 30-day readmissions after hospitalizations. We talk a lot about clinical AI being used for diagnosis and identifying appropriate treatments for patients. But what we see actually most commonly in hospitals are these three applications: scheduling, predicting adverse events, and doing follow-up. Next slide, please. Between 2023 and 2024, we also saw the most growth in these two administrative categories, scheduling and billing. We didn't see very much growth in clinical domains of AI use in hospitals, but we saw considerable growth in scheduling and billing. Next slide, please. This is important because when I do interviews with hospital decision makers across the country, when they talk about clinical tools, they have a good sense for what the kind of hopes and risks are. They have a sense of medical liability. They have a feel for what might qualify as a medical device under FDA. They know that if they have questions, they kind of look to FDA. There's kind of an understanding of what the rules of the road are with the clinical side of things, much more so than the administrative side. When people talk about administrative governance, they're a little unsure. They know that they don't turn to the FDA to ask questions about an administrative tool for scheduling or billing, but it's not clear who they look to really for best practices or guidance for that category of tools. Similarly, there are hopes and risks related to administrative tools, like we hope that we can reduce cognitive burden for clinicians doing documentation, but there are also concerns about quality and how these tools are impacting a patient's access to care and the quality of these tools. One particular example is a very popular tool designed to predict if patients will miss their appointments. One of these tools was using a patient's ethnic identity and religion as predictors, right? So these tools are not likely to misdiagnose a patient or prescribe the wrong medication, but there certainly are risks related to their implementation. We just don't have the same kind of quality or clarity in terms of guidelines for these tools. Next slide, please. Quality and evaluation presents a real challenge for healthcare delivery organizations. Like I mentioned, generative AI is a particular puzzle because of its probabilistic nature, because its output can change even given the same inputs. But even beyond that, organizations struggle with conducting evaluation and ensuring quality of AI tools for a variety of reasons. The first is that there's generally low capacity to conduct this kind of evaluation work with a real digital divide. I mentioned that rural hospitals and critical access hospitals are less likely to be both implementing and evaluating AI tools, but even across the country, only 57% of the hospitals using AI are conducting evaluation. So we have a lot of progress to make here in terms of ensuring that the tools that we're using perform well and are providing value. The second challenge is limited guidelines. Like I mentioned, with administrative tools in particular, lots of decision makers are kind of unsure of what the rules of the road are and routinely express the kind of desire for some guardrails around what they should be using and how they should be using it. The third challenge is a lack of transparency on the part of vendors or model developers. In order to make a decision about if a tool is going to work in a particular hospital or clinic, decision makers need to know what the tool is, what it's supposed to do, what kind of data it was built on, and if it's likely to perform well for their patient population. Without those key informational elements, their hands are kind of tied. Even if they are really excited about implementing AI, even if they see potential value in it, and they're hopeful about its impacts for their clinicians and for their patients, without those key informational elements, it is really difficult for them to feel like they can move forward. They need that information from the vendor or the developer in order to make good decisions. The final challenge is access to expertise, and this is particularly true for rural and critical access hospitals and other low resource settings. In one interview with a hospital decision maker in a rural area, she was telling me, I know that we're supposed to involve lots of stakeholders in our decision making. I know that I should consult an ethicist, but we don't have an ethicist sort of in-house, let alone in this area of our state. Similarly, many of these organizations struggle to access data science expertise that they need to evaluate these tools. This makes it a real challenge for organizations. Next slide, please. So in closing, that kind of snapshot of what AI use actually looks like in the US healthcare system. Most hospitals are using AI, especially predictive AI. About a third have already implemented generative AI, but evaluation lags implementation. Not every hospital is evaluating the tools that it's deploying. There's a real digital divide for rural hospitals that we see consistently year over year, and those hospitals with lower operating margins. Administrative uses of AI are growing, but also present a real puzzle in terms of evaluation and guidelines. And so some of the kind of potential strategies to address these challenges include technical capacity expansion to build data science capacity for evaluation, clarity on best practices, and access to key information about what these tools are and how they work. Thank you so much. I look forward to your questions after the next presenter.
Thank you, Thank you very much, Dr. Nong. And we'll go to our final presenter and then open it up to members. Dr. Peter Lazis. Oh, there you go. Hi.
Here you go.
Dr. Lazis. How are you?
Good morning, everyone. Thank you, Franco, and the chairs of the two committees. I'm honored to be here. A little about my background. I'm a clinical and industrial psychologist. In addition to education and research, I've been actually in the trenches as a consultant to groups like Martland Medical Center in Newark after the uprising in 1967, Sunchip Dry Dock Company in one of your great towns of Chester, Pennsylvania, Saturn Corporation, and Los Angeles Department of Health Services. So I will share with you some of my thoughts. I also want to reflect on some of the questions that were raised earlier about, does this save money for patients, issues of staff, where do you go from here? And so I've divided my short presentation about understanding the context of AI, how the tools are being developed, who's developing them, and how that then leads to specific outcomes of the workforce and staff. And I've taken the liberty to suggest some potential legislative initiatives in addition to your governor's proclamation around AI as a way of thinking about what could be done. As our two other speakers have talked about, AI is having a major influence on the workforce. But it's important, I think, to start with a quote by Terence Tao. He's an internationally recognized mathematician at UCLA, and he recently stated in the New York Times that is in an article about, is AI able to generate new ideas? He said, listen to this, it feels to me like a really clever student who has memorized everything for the test, but doesn't have a deep understanding of the concept. And I'm going to drill down on this information about what's behind how the workforce is responding to AI. Companies in healthcare that are developing AI tools include Epic, Oracle, OpenAI. They're developing tools mainly, and I think our two speakers focused on this, to cut costs. Focusing more broadly on improving diagnosis, drug discovery, patient monitoring, and administration. What it leaves out is that the processes really need to be what they call code-generated or human-centered. This comes out of work at Carnegie Mellon and MIT, meaning that for AI tools in general, but specifically in healthcare, the frontline staff need to be involved. This is not a labor relations perspective, but an evidence-based perspective by technology experts. Unfortunately, it is quite rare that frontline staff are actually involved in the process. This is very similar to what happened, unfortunately, with electronic health records. It was created and used and resulted in major amount of time of clinicians having to input information into the electronic medical records that were really not about clinical issues, but really about billing. And this has caused significant doctor and nurses burnout. We're seeing the same scenario right now with AI. AI tools are being developed by the companies I mentioned and several others without any frontline involvement for the most part. Occasionally they are involved, but it's very rarely. And so the tools are not then being focused on the problems of frontline staff. And also on implementing these tools effectively sometimes takes place, but the development of the tools, I just want to emphasize this, is not on the pain points or the problems of patients and staff, but on the ways that these companies are making money without consultation with these important stakeholders. It's being developed it's being agreed to by the C-suite employees focusing on reducing costs. And yet the tools are touted in the literature that it improves patient care and working conditions of staff. What concerns me and the question I raise is, why aren't the clinicians involved with this development? This would make better sense if we're really talking about, and one of your colleagues said about saving money for patients, ways that would save money for patient, not for increasing billing for that organization, or doing both. So I want to then shift to how it impacts frontline staff, and this is what your colleagues asked me to comment on. As a result of what I've just said, that these tools are being developed not by clinicians or with clinicians, but by AI companies, it's requiring a lot of time to correct patient information, shift-to-shift notes. And as I mentioned just a few minutes ago, this is very similar to what happened with electronic medical records. A second outcome is that there's a lot of resistance of potential use of AI tools because the caretakers, whether it's a nurse practitioner, a doctor, they haven't been involved in training them. So these tools cause them to feel a loss of autonomy quite often, fear that it might impact their licenses. This is particularly true of nurses, and concerns of patient privacy, misuse of information, and misuse of monitoring, as the last speaker talked about, the work that's going on. In important cases, particularly of call centers and whatnot, there's a fear of losing their job or decision-making about their work, since management tends not to communicate how the technology will be used until it's actually implemented or being forced upon people. When tools are helpful to clinicians, they are not told, stay with the number of patients you have. They're told, increase the number of patients so that you'll see more, rather than coordinating the care with specialists when people have more free time. I just want to emphasize that. So let's say a doctor or nurse gets more time freed up because of use of various technologies, including AI. They're not encouraged to use that time to better improve the coordination of care for those patients. I gave several examples in the in the material that I sent to you about some of the examples, but I'll just say, I'll just highlight quickly a few others. At Duke University, they developed an AI tool to help reduce the use of ICUs by anticipating heart attacks in the emergency room department. Unfortunately, and that would be reducing the crowd, the amount of patients in ICUs. Unfortunately, the ER doctors were not consulted with the folks who were developing this AI tool and refused to accept it. We don't need, this is a quote from them, we don't need a tool to tell us how to do our work. A medical center in the Northeast was trying to get patients off regulators and ventilators and to improve the coordination of care. And doctors then developed, without the involvement of nurses and ventilation therapists, their involvement, and it was seen as not being important because the burden that these clinicians were having was on documentation that was contributing to burnout. I can go over a few more examples, but I'd like to get to a few other important points. So how has the workforce reacted to this? And there's kind of three basic ways they've been reacting, and I think will continue to react. To a large extent, frontline staff, particularly in non-union hospitals, feel the best way to respond to being forced, use that word, using AI tools is just wait and see what management decides to do, and then adjust things by creating what we call workarounds, things that can be done to work around the burdens of AI documentation similar to electronic medical records. A second strategy, and one that many nurses unions, particularly on the West Coast, are using, is using collective bargaining language to create various ways to block the use of AI, establishing guardrails, and the hope that this will stop AI. I don't think it will stop AI, but it might temporarily make a pause in a situation. I think what we're seeing now, and I forgot to mention, I'm at Penn State as a visiting scholar. The third approach is more systemic. It really is a multi-pronged approach. One is establishing guardrails so that it reduces or controls job losses, protects the rights of patients, and honors the licensing of clinicians and the autonomy of clinicians, as well. So that's similar to the first one, but it also encourages co-generated processes with frontline staff to identify problems, as I mentioned before, where AI may be helpful to improving the working conditions of staff if they were consulted, and better patient care. This collaborative process is actually, as I mentioned before, being touted by groups at Carnegie Mellon and MIT as the only way to really effectively implement and develop AI tools. And the third part of this systemic approach, which relates to you and your roles, is creating state and federal laws, policies similar to what your governor has already started to do, to encourage labor and management to work together to create co-generated, some people call it human-centered, uses of AI. So where does this leave us? To me, the real question is not, will AI be useful? The question is, who decides where and how is it used and who benefits? And I'll just close with 3 areas that I think state authorities such as yours could continue to do to deal with generative AI and the potential use of it to improve patient care and patient care outcomes and to reduce burnout of staff. One is to strengthen the state policies that you already have about generative AI to make sure healthcare AI tools are used in a co-generated process so they don't put at risk patients and healthcare staff. I think the governor's proclamation had 8 principles to it. I would support that. Establishing funds to provide frontline staff, healthcare employees, educational programs about digital literacy and opportunities to learn new skills, particularly for employees who are at risk. This follows the model that is currently going on in the educational, arena with Microsoft and the American Federation of Teachers, where they're co-developing literacy programs for staff. And the last one is potentially establishing funds to encourage healthcare organizations to use a co-generated process to improve working conditions and improve the access and quality of care, similar to other innovation funds that have been used in economic development strategies in other states. Thank you for enabling me to share my thoughts with you this morning, and I'm open to your questions and feedback. Thank you.
Thank you very much, Dr. Lazis. We'll now go to members. Let me start by asking a question probably directed to Dr. Nong. Can you talk about AI evaluation? Why is it important? And what could happen to patients if AI isn't evaluated?
Yes, absolutely. Thank you for the question. So AI evaluation is important to make sure that the tool is operating properly. We've seen problems in the past in the healthcare system with the tool being developed for one patient population and then being deployed for another. This happens for a variety of reasons. It's because different health systems or organizations capture data differently, process it differently, and their patient populations just look different from each other. So if a tool is developed at Duke, for example, there are particularities of how they collect their data, what their patient population looks like, that mean that a tool that performs perfectly well there might not actually perform at mHealth Fairview here in Minneapolis. we might collect our data differently. We might process the data differently. And our patient population certainly looks different from Duke's patient population. But if we don't evaluate the tool, if we don't look at its performance in our patient population, there's no way of knowing that. So in order to make sure that the tools are operating well and that they're producing value for a particular organization, they need to be evaluated. Similarly, with a generative AI tool, it's important to make sure that a tool is not hallucinating, that it's not sort of inventing information that makes its way into a clinical note. If it does, you can imagine a tool, if it hallucinates a fever, when a patient doesn't actually have a fever, the clinical decision-making that results from that information will look different, right? And so we need kind of guardrails, we need ways to make sure that the tools are operating properly in practice.
And I would just add one other piece to it. The evaluation, as Paige had said, earlier, is weak. Most of it's being done by the vendors themselves, and I will echo again issues around the workforce. This is important for the workforce to be involved in. They're the ones who are using them, and the major challenge we face is that frontline staff, I'm talking about, doctors, nurses, lab techs, are not being consulted at various stages of development and an evaluation. And so evaluation by a vendor or by the C-suite, unfortunately, they're too far away from the situation to know what's going on, to actually customize it and to make it useful, those tools that are really important.
Chairman, you're muted.
Sorry about that. If members could please raise your hand virtually, I'd recognize you. I'm looking here. You seen anybody? Well, let me. Can you give us some examples of where AI is working for frontline staff?
I'm sorry, Chairman, was that for me?
To anybody there, that would be great.
Sure. Yes, so I think that what we've seen over and over again with evaluations of ambient scribes in particular is clinician satisfaction. What we've seen, and Dr. Neprash, of course, can speak to this as well, we've seen evaluations of ambient scribes looking at clinician satisfaction, the time they spent on documentation. We don't see a ton of actual time savings, but we do see improvements in clinician satisfaction, right? So there's clearly value here for frontline workers in a way that improves their daily lives, even if it's not saving them a ton of time, which is sort of what people anticipated would be the value of the ambient scribe. But I'll pass it to Dr. Neprash.
I absolutely agree with Dr. Nong's take on ambient scribes, and would just add that another area where AI seems to be working very well for clinicians is radiology pretty broadly. There are a lot of predictive AI tools that are being used to triage medical imaging review to prioritize potentially time-sensitive conditions. A good example would be pulmonary embolism detection. And those are being used at this point very broadly across diagnostic radiology.
The only thing I would add to this is, and this is good dialogue. There are those who really appreciate ambient scribes because then doctors or nurses don't take notes. But there are several particularly doctors who are concerned. In fact, the American Medical Association has just set up a office for digital and AI technology, because there are members of them who feel like the actual notes that are taken are not accurate, and they're spending more time correcting the notes. So this is not a slam dunk situation. There's also evidence of shift-to-shift notes that are ambient scribed that are not accurate. So it's whether those reports are accurate. I can't really vouch for that, but there is a strong consensus that because the end users are not involved, some of the information that's being captured is not accurate, and some of it's not relevant. And you know, shift-to-shift notes for nurses are really critical for being, particularly with high acuity levels of patients, and that the ambient scribes that are being used are not capturing all the critical information about the lifestyle of that patient, the economic needs of those patients that are playing into being healthy once they leave the hospital. So there's a lot of questions that are going on. I wouldn't say that it's a slam dunk that ambient scribes are great. To some doctors, it's a windfall. They're tired of writing up notes, you know, and so they have, you know, the technology to do that for them. So I think it varies. There's a lot of unknowns that we have right now of how it's impacting our workforce.
Thank you. We have in order Representative Borowski, Representative Nelson, and Representative Torzik. Representative Borowski.
Yes, good morning. Thank you, Chair Frankel, and thank you to the presenters for this very informative presentation. Certainly a lot of pros and cons around the use of AI in healthcare, and I appreciate you all laying out all of those. I guess for me, the one of the biggest concerns being about the accuracy of the notes and things like that. Definitely with the scribes, that could be a concern. As we go through all of this, and one of the things that we as legislators are struggling with, so not only how to get our arms around the use of AI in various fields, but the way that AI is powered, so the data centers and things like that that are kind of behind all of this, making it happen. Do you feel, and maybe this is like more of a, I don't know, philosophical question, I guess, or maybe I'm asking you to predict the future. Do you feel that this is something that is definitely going to take off, become completely, you know, very prevalent? I mean, I think to me, a lot of the cost concerns that were raised in the first presentation, you know, are definitely concerning when it comes to healthcare, where health, you know, the cost is already so astronomical in many cases. Do you think that it is worth the investment in some of these things, these data centers and things like that, where communities are very concerned, or you may be in many cases opposed? Do you think these are worthy investments looking forward? I guess I'm looking for some sort of, I don't know, future vision. I don't know. Sorry if that's a loaded question.
Anybody who wants to weigh in, please do.
I'm happy to kick it off. I share a lot of your you know, desire to be able to see into the future, to know how this will change our lives. I do think that, broadly speaking, we will never go back to pre 2017, you know, before we had large language model technology. I guess that was 2022. I think our world is different, and I think AI is a transformative technology. I also think that it is, you know, as we build the infrastructure, it is tremendously important to be conscious of the resource use and of how generating the energy and of the water use, how that falls differentially on certain communities where those data centers are located. I applaud your concern.
Dr. Lazarus, I thought you wanted to weigh in on that.
Yeah, I would just echo a little what Hannah said. I would just temper it a little, saying, the large language technology opportunities of AI are really important for diagnosis and predictability. I think it's a question of controlling more of where AI gets used, or stated a little differently, making sure it's really focused on the problems that our healthcare system has around workforce burnout, access to care, coordination of care. And unfortunately, I don't see that being the focus of many of the AI tools now. On the diagnostic side, I think it has tremendous potential. If it's used well. I mean, one of the other pieces of research recently is how doctors are responding to questioning their authority and their judgment call, which I think is a danger of the technology. So I think the question is, can we make sure that AI is being used around the right problems of our healthcare system, not just decided by firms that are developing AI. And I think that's where legislative initiatives can help guide that discussion in the right direction. I think it has a lot of good uses, but it's sort of on a free fall right now of almost anything that seems to be important to these companies. I think clinicians have to step up too, to say that these tools need to be used in these directions rather than just waiting on what tools are coming down the pike. And I forget whether it's Hannah or Paige mentioned, there are limits to the resources in many healthcare settings to think about this, and including unions, to think about how should they address the concerns of their members and the concerns of patients. So
thank you. We set the framework and plug in AI where we think it works best, as opposed to is developing it and telling us how we're going to use it.
Right, exactly. Yeah, and I think state legislators and unions in particular have to set that kind of tone. You hit it on the head. It should be driven. And in fact, I am now working with a group of doctors on the West Coast who are doing exactly that. They're saying, where can AI be helpful to us to deal with our burnout and frustrations? And it's a start from there, and then you get the companies to work with them and the IT people to develop or modify tools to address that, rather than saying, oh, you should have scribes because that's important to you, when in fact, that's maybe not the important thing that those physicians need to be concerned about, or are going to help them or help the patients. It surely doesn't improve access to care if, as I said earlier, if physicians and nurses get freed up and the policies of those hospitals is saying, oh, by the way, Lisa, now that you have a few more minutes, you're going to see 3 more patients. That's not going to help the situation, So there's a kind of systemic way of making sure that AI tools are going to be used to do better for everyone, both patients and the staff and the C-suite. I'll just digress. I remember being at Cornell, and we started having computers, and everyone had, IBM typewriters. And then people got computers, but nothing else changed. Everyone was using the computer as they were using a typewriter. So the systems of care actually have to change along with these great tools. Just plugging them in is not sufficient. in a broken healthcare system that we have.
Great. Thank you.
Yeah.
Representative Nelson.
Thank you. And I think that that question is kind of the perfect lead into my own, and my general thoughts are, given all that AI is potentially going to bring to the country and the world, from a public safety perspective, from a war and the execution of war perspective, the one space that we can at least hold out significant hope is breakthrough change in healthcare, from drug discovery to more accurate and timely care and treatment plans. So I kind of come at this conversation and this policy space from an area that says we're still very much in the infancy of AI. It's not going to be, this bad again ever. Right? If we understand that the AI systems that we're kind of regulating for now are really the systems that will be built 2 or 3 years from now, 5 years from now, I ask us all first to say, let's assume that that hallucinations are kind of answered. Let's assume that we expect highly accurate AI systems, and this particularly from a kind of the decision support or the clinical decision support systems. Given that as being the case, how should we think about where we establish boundaries and where we expect a highly informed and accurate AI system to help dictate treatment plans? I'm equating this almost to an astronaut or a pilot and their interactions with, NASA command and control or an air traffic controller. How do you believe we should be governing the work of physicians or nurses when they're interacting with, again, a highly accurate AI clinical decision support system?
Thank you for the question, Representative. I think there are a couple of really important pieces of what you were just describing. I think the smartest question that I've ever heard from a chief health AI officer was, does this need AI? And that's sort of like the beginning of all of their subsequent decision-making about AI implementation in their healthcare system. Because for some things, and to the previous question, for some things we can justify the cost. Right? AI is not cost-free when we think about, data centers and energy use and computing capacity. It's not cost-free. So where can we justify the cost? And how do we enable organizations to be judicious in how they deploy and use these tools? Whether we're completely confident in their accuracy, or if they require sort of continuous monitoring and evaluation. I think the other piece is that even given evolution of these systems and these technologies over time, transparency is always important for healthcare delivery organizations to be able to make decisions about what they use or don't use. It's very important for them to be able to get the information that they need from a vendor that's selling them a tool to make decisions for their patient population and to make decisions about what their clinicians will have available to them or what their nurses will have available to them in the electronic health record, for example. So I think when I think about kind of the future landscape and what will endure and what might evolve, I think that need for transparency will be there regardless of how accurate a tool is, or if we feel increasingly confident that hallucinations will decrease, for example. There is kind of one note of caution there on the inexorable movement toward improvement or toward progress. Our progress in a sort of patient-centered way, or our progress in a high-value care direction, is contingent on human decision-making. Right? These tools can do considerable things autonomously, but in terms of guiding the direction and deciding which values we're pursuing as we implement AI, that rests on human decision making. We can decide to use an ambient scribe to upcode and to be more aggressive with billing. Or we can decide to use an ambient scribe to support clinicians and reduce burnout and make sure that they're able to engage with their patients. The human decision making is going to be really important regardless of how advanced a technology becomes.
Thank you.
Chairman, you're muted.
Sorry about it. Representative Torzik.
Good morning. I really appreciate the time you guys have spent giving us an input on AI. I've served on a hospital board, and we're working hard at trying to make sure that it helps our staff do a better job. And anybody who's gone to the physicians, doctors lately are happy to have the doctor spend time with you as opposed to sitting there at a computer taking notes. But it's brand new technology. We have to give it a chance. And again, the good news is our hospitals are working such that there's a lot of feedback. I sit on a professional care committee, so every month we review what's happening in our hospital, how our service is doing, how our customers are being taken care of. And this is going to be an important tool for the future because we need to make sure the experience of people coming into our hospitals improves. And from a staff standpoint, thank goodness we're going to take away some of the monotonous work and get it done. But there is the safeguard that everybody needs to sign off on their data. After they do their review, they need to look at it. But this will give us a little more time to work forward. But is there a giant, what's our biggest fear? What should we look at as legislators to protect our patients, customers, and healthcare system? It was the top one.
Anyone want to take that?
You know, I would piggyback what Paige said. I think transparency, you know, about what's going on, you know, what the need is and how AI and other technologies. AI is not the only technology that can be helpful to us in the healthcare space. And it's sort of what Paige said a few minutes ago about, you know, what are the areas that really are important that need to be identified. But I would say that, you know, transparency about what's going on at the point where decisions are being considered, not when they've been made and how do we implement it. I would say that would be my top choice or suggestion, Tim.
Appreciate that because, you know, I was on the board long enough when the medical records came in, the electronic records. And you'd spend a lot of time with some of our old time providers who weren't very comfortable, unhappy about sitting in front of a computer and getting the things done. And it came to a point where we had to encourage that we need to get it done because guess what? If we don't get these implemented and done, we don't get paid. But we're working hard. I think this really is going to be a big benefit for healthcare because our people are getting burned out. And if we could make their job a little easier, they're going to enjoy working longer. The patients will have a better result. And, you know, we don't take it lightly. Again, when we put robotics in, that was the answer for an awful lot of things. And you found out how expensive the consumables were. So you cut back and say, okay, where does it really work for the patient? And this is the same as AI. How's it going to really work to help that patient? Because that's really what we're there to serve in the healthcare system. Thank you.
Yeah, I would just echo, you know, Tim, that, you know, one of the examples of good implementation of electronic medical records was done at Kaiser Permanente. And they didn't do rocket science. They basically engaged their physicians and nurses in the development of their electronic medical records, and then their implementation became very easy because they had already bought in to what was going on and had their advice of the clinicians. So I think, you know, the other part of it is, I think we have to think differently about how decisions are being made about technology. It needs to be out of the C-suite and senior management and more around line management and frontline staff thinking about what you've talked about. How do we make these tools really work? And what tools do we need that we don't have that could be used? And I'll go back to my example of Microsoft and the AFT, the American Federation of Teachers. What they're finding is that the discussions between teachers and IT people at Microsoft is creating different tools, because they're finally speaking to the teachers and saying, what do you need? And let's then figure out how some of our tools should be adapted, or should we make other tools? So I think there's a important opportunity here. If we're going to make use of AI, we need to think about decision-making about that in a much different way than currently going on, so that the great things that can be achieved by this important technology are actually done. I think going back to my example of the IBM typewriter, I think if we just try to fit the AI tool into the present system, it's not going to be optimized. And in many cases, rejected by clinicians because of not being accurate to what their problems are, or feeling that their autonomy is being lost because they haven't been involved. That would be very sad if we have some great tools that people just are unwilling to accept, because they haven't been included in the thinking process.
Absolutely. And again, the nice part is the feedback. The best management practice is to get right down to the people doing the work, listen and find out. And we do that through our roundings and our committees. And we're trying our best. It's a difficult business because the patient coming in is very unhappy because they're not feeling well. And our job is to get them as well as we can, as quickly as we can, and don't let them come back.
I'll just end with one other piece of this, Tim, is, with the challenges that healthcare have in general, access, quality of care, the burnout, we're also dealing with significant changes in Medicare and Medicaid expenses. And why shouldn't the workforce be part of the process of solving that problem? It shouldn't be just a burden of management. We need to, recently I've heard at Kaiser, $7 to $10 million in the Northwest region was saved by frontline staff coming up with suggestions for change. All of our healthcare systems are being challenged economically as well as clinically. And the question is, how do we get to a better way of optimizing the skills of the frontline staff in that problem-solving process?
Right. We all have to remember to thank our frontline staff, because they're the people who really do take care of everybody in our system. Sometimes we forget that, but we are very conscious of thanking them for coming to work every day. Thank you, Doctor.
Thank you. Looking to see other members. I don't see any hands up. Who? I'm sorry. You saw something?
Dr. Nam was going to say.
Oh, sorry. Go ahead, Dr. Nam.
Oh, sure. Just a vote for my wish list for keeping patients safe and making sure we're doing this well. I would say model cards and investment in evaluation. So model cards are basically a nutrition label for an AI tool. HTI-1 was previously sort of a requirement that certified health IT vendors provide that kind of nutrition label for a tool that they were providing to their consumers. It will not be in place any longer, but the idea of the model card has been around in AI circles for a very long time. And just kind of providing that basic standard information about a tool is really useful, especially across that digital divide that I described. So for decision makers in a critical access hospital or in a federally qualified health center who don't have a large data science team in-house, providing that kind of basic standard information by the vendors would be a huge step forward in their ability to evaluate a tool and decide if it's going to work for their population. And I think investment in the kind of evaluation capacity that's necessary to make sure the tools work properly would be hugely valuable. I think Dr. Neprash also maybe had a thought.
I apologize. I think I'm responding to a variant of the question, which I heard to be, what is your biggest concern? What is your fear about AI? I think that in the immediate term, I have two specific to healthcare. The first is that AI will create an even larger divide between the haves and the have-nots, the well-resourced providers and the critical access hospitals and safety net facilities that may not have the resources to do some of the experimentation, right? To try AI innovations and see what works for them. The other concern I have, we haven't really talked about the role or the way that insurers and payers are using AI, but it does seem that it's becoming increasingly adversarial, and that AI is a tool being used by payers to restrict, potentially deny care, and that is just setting up an even more adversarial situation between providers and their patients versus payers and their desire to constrain costs. And I see the perspective on both sides. I think it's a tricky needle to thread.
The feedback, and again, everybody hates to get that letter saying service denied.
Yep. Thank you. Representative Stair.
Thank you, Chairman, and thank you to the testifiers. A question I had with the inaccuracies and everything like that, who assumes the liability for the inaccuracies? Is it under hospital policies? Is it under malpractice insurance for the doctor or the nurses? Who in particular would be kind of liable for inaccurate information?
I'm happy to jump in and first and foremost say that I am not a lawyer. I am an economist, but I am married to a law professor, and I talk about this question with him quite a bit. It really sounds like we're at the beginning of the journey of figuring that out. There are some initial cases that are making their way through the court system, but our legal system does not move quickly. And so setting the precedent for how liability is apportioned when AI is involved in mistakes that affect patients, I think we do not yet know how that will fall.
How do the insurance companies feel about that information? I mean, is it going to be increased rates, knowing that there's a chance that a particular hospital or individual is using the AI for diagnosing a patient? Is there going to be like an increase in their malpractice insurance, or, because the liability does go up if the information is inaccurate at times?
That is a great question. And if I'm confident of anything, it's that insurers will pass on higher costs to providers who are purchasing malpractice policies. That will certainly happen. On the flip side, though, it is possible that if we have such good diagnostic supportive AI-enabled technologies, it may be that it actually becomes, if you have adopted some of those, it reduces your malpractice concern. If that becomes the standard of clinical practice, we're still a little ways away from that, but I think it could go both ways.
Thank you. Let me ask you, I mean, you talked a little bit about the issue of pre-authorizations and how it's manipulated. I mean, the economic interests that round counter to reducing costs, both with respect to payers by, the algorithms they end up using to do pre-authorization. And then I think one of you also talked a little bit about the issue of like the upcoding by the providers. Have you seen any approaches in any other states that kind of address these kind of adverse incentives that are out there for what I would characterize as the misuse of AI to increase costs on one hand and deny access on the other?
I can answer that. There are at least 3 states I can think of, and I'm happy to follow up with this, that have enacted legislation where the flavor is basically limiting the use of AI exclusively to either make denial decisions or determine prior authorization decisions. So that is certainly something that the requirement there being that insurers can use AI, but there needs to be a human in the loop somewhere so that AI is not the ultimate decision maker. I have not seen, however, any sort of legislative action aimed at kind of tempering the incentive to use AI to upcode and maximize billing practices. I suspect we'll see that in the coming couple of years. I would happily work with you if you're interested in.
Absolutely, love to talk to you more about that. So, Dr. Lassus, are you going to weigh in there too?
I don't have any knowledge of any states taking any initiative at this point.
Well, thank you. I want to thank our presenters. It's been really very, just a great hearing, very informative. I'm sorry, Representative Nelson had another question, comment?
Yeah, I just typed in. I've heard actually some practitioners are seeing insurers actually down coding when AI is being used, as they're effectively saying that a difficult decision wasn't actually as difficult as you build it to be, which is fascinating. And again, it just speaks to the agency dilemma that comes with deploying AI systems. And I think the last piece for me is, I think that liability question that Rep. Stair mentioned is really the dramatic one, because, and we're seeing it with autonomous vehicles as well and other AI deployments, is if we get to a point where we believe the AI system, the decision support system, is actually accurate, what happens if a physician chooses to do something that the AI system suggested otherwise? Where does that land? And at some point, do insurers say, as I mentioned before with autopilots, it is no longer okay for you to turn off the autopilot. It is no longer okay for you, or at least you must explain why you chose to do something different than what the CDSS says. And that is kind of principally my concern with where we are right now with 1925, is just helping me understand. And for the presenters, please, I will send you an email. I won't continue this hearing any longer, but please, this is what I would love for you all to help me unpack, is how do we understand that liability concern when there's expertise?
I would say that, one of the pieces of the liability, building off of Hannah's comment, it's not really clear who's at fault at this point when a nurse uses an AI tool to determine the acuity level of a patient. Is it her, him, or the AI tool that causes a potential death? I mean, that's it's a big question that needs to be thought through carefully. And Dan, if there's any other follow-up that any of us need to do with you and the rest of the two committees, please feel free getting in touch with us.
Yes, we certainly will. We have all your contact information, and we'll certainly make it available to other members, and we'll have it here at the Health Committee. I want to again, express my profound thanks to Dr. Naprash, Dr. Nong, and Dr. Lassus for their participating this morning and their patience in dealing with our scheduling and the weather challenges that we've had here in Pennsylvania. And with that, I'd like to invite Chair Cerisi to close us out with his perspective.
Well, thank you all very much. The testimony I always find very interesting as we get into this area of AI because it all is all so new and scary on so many ways. Not scary in that it can't help us, but not knowing where it's going to go and how it's going to be used. And, of course, we always hope that everyone is doing it for the right reasons, but we know at the end of the day, there are people who do things because they feel like they just want to do it. And then we also look at saving money, which we heard a lot about, and cost cutting and the insurance company's involvement. And I think as we evolve, I hate to use that word as we're talking about AI, but as we evolve in understanding AI and the use of medicine, we will see it by 99.9% of the people be used the proper way and the right way for the right reasons. My fear is always that insurance looks at this as a money-saving mechanism that we heard a lot about and uses it to cut corners. And that's not what we want. And I know definitely Dr. Venkat, who's on this, has been a huge advocate of making sure we don't see that happen. And I can't thank Chairman Frankel for being part of this in the Healthcare Committee with everything that they're doing for the Health Committee on this subject and other matters. But I look forward to speaking with all of you in the future and working together to find the right path forward for Pennsylvania. I just wish the federal government would wake up and start doing something on the federal level. Someone just asked me the other day, well, what do you think? I said, I think they should do their job. I don't care what party it is. I think we should have federal guidelines on everything that we've been talking about, but we don't. So it's our obligation as a state to make up obligations to the 13 million people here in Pennsylvania. So thank you. Thanks again, Dan, for this. I hope to see everybody in Harrisburg in the coming week, even though there's another snowstorm coming in from what we saw just in the weather report. But it is winter. What are we going to do? Stay safe. Thank you.
I just want to also offer an opportunity to my counterpart, Chair Rapp, for closing comment.
Thank you, Mr. Chairman. This was very informative, and a lot of times hearings like this present us with more questions down the road when we think things over. But I appreciate all the testifiers. Thank you for being here today. It was very informative, and it is an issue that I think we need to be concerned about and look forward to the challenges, that all of AI brings to not just the medical arena, but to every arena in our lives. So, but thank you, Mr. Chairman, for putting this together. I very much appreciate it, and want to thank all of our colleagues too for their very informative questions. Thank you, sir.
Again, thank you, Chair Rapp. Thank you to our testifiers. Thanks for the members participating this morning and for your input. This was one of two panels. We will reschedule our other panel, which includes a number of different stakeholders. And again, thanks so much, and look forward to talking about addressing this issue legislatively as we move forward. Good afternoon. Take care.